Module 7. The child with a musculoskeletal disorder. With the growth and development of the musculoskeletal system, we see the long bones growing from the diaphysis to the epiphysis. I'm sorry, my tongue is just not working right today. In utero, the fetus basically doesn't have the bones per se. They have a lot of fetal cartilage, and that cartilage will change to bone in certain areas. Now, I'm not saying that they don't have any bones, because they do, but a lot of their bones is more cartilage. During childhood, the bones are going to be more sponge-like in consistency. Most bone growth will be completed by the age of 20. The bones of the skull are going to give shape to the head, and the infant, they have those suture lines when they're born. They will harden within the first couple years of life. There's also 4 distinct curves to the spine that form as the child matures. It provides support, strength, and balance. And their muscles become stronger. They develop more muscle tone, strength, and coordination. With fractures, we know this is a break in the bone with vascular and soft tissue damage that causes pain, swelling, tenderness, and decreased function. Children's fractures generally are less complicated and they heal more quickly, and they occur from different causes than adult fractures do. The most commonly fractured bones in childhood include the forearm, wrist, clavicle, humerus, femur, tibia, and fingers. We have the different classifications of fractures: the complete, incomplete, green stick, spiral, closed, open, and crushing. Most fractures will be treated with realignment and immobilization using either traction or a closed manipulation and casting. But if the fractures are severe or there are additional injuries, they may require surgical reduction, internal or external fixation, or both. NSAIDs or opioid analgesics will be administered for pain. It's important for nurses to manage pain appropriately and assess the neurovascular status. Those are priorities. The type of cast will be determined by the age of the child, the severity of the fracture, the type of bone involved, and the amount of weight that the child is allowed to bear on the extremity. Might be made from fiberglass, polyurethane resin, or plaster. They do require proper care, maybe pedaling with the adhesive tape strips to help prevent rough edges around the cast, and apply plastic if the cast is close to the genital area to prevent soiling of the cast itself. The cast must be allowed to dry completely, and it's important to monitor for compartment syndrome. If we see compartment syndrome, this is a serious neurovascular concern that has to be reported and addressed immediately to prevent permanent damage. And we need to assess circulation, movement, and sensation, which includes observing, documenting, and reporting the 5 Ps. That's the pain, the pulse, again, making sure we're checking distal pulses, paralysis, pallor, and paleness. Also check for any foul odor or drainage on or under the cast. Palpating for hot spots on the cast, because this can indicate an infection. Making sure the cast is not loose or too tight. Monitoring the client's temperature, and instructing the family of signs that they need to watch for and report immediately. When the cast comes off, it's very important to provide appropriate education because that cast cutter can be kind of scary, even if you're an adult. Make sure we're elevating that extremity at or above the level of the heart for the first 2 days as much as possible. Apply ice packs over the cast for 20 to 30 minutes every few hours while the child is awake for the first couple of days. And continue to apply ice packs if swelling is present or there's a lot of discomfort. Unless it is one of the casts that is allowed to get wet, make sure that cast stays dry, covering it with plastic, and never put it in water. If it does get wet, we can dry it with a hair dryer on a low setting. And consider covering the cast when the child is eating or drinking to prevent soilage. If it does get soiled, a slightly damp cloth may be sufficient to clean it. Instruct the child to never put anything inside the cast, and that will include small toys or sticks or stick-like objects. Never put powders, deodorants, or let dirt or sand get inside the cast. If there's a lot of itching, we can always blow cool air from a hair dryer or a fan into the cast. Really important to teach the child to report immediately and for the nurses and the family to monitor for pain, cool skin, or discolored skin, especially bluish color, or if the skin becomes very pale, red, or irritated, if there's numbness or tingling or swelling, an inability to wiggle the fingers or the toes, or a foul smell coming from under the cast, or the client has an increased body temperature. Once that cast comes off, instruct the client to soak that extremity in, or to soak it and then gently clean and pat it dry. Never rub the skin or peel off that excess skin. Putting lotion or oil on to the area to help with moisturization, and applying sunscreen where that area had been casted previously. With traction, if you remember, we're using a pulling force applied to the extremity or another part of the body with a system of weights and ropes and pulleys to help realign and immobilize fractures, reduce or eliminate muscle spasms, and prevent deformity and joint contractures. With skin traction, this applies pulling on tape, rubber, or plastic material that's attached to the skin. Indirectly, it can exert a pull on the musculoskeletal system. With skeletal traction, we have the pin, wire, tongs, or other device that is surgically inserted into the bone and exerts pull directly on the skeletal structure. Very important, once again, to ensure that those weights stay off of the floor and the child stays positioned correctly in bed. And we must carefully monitor the child to detect any signs of neurovascular complications, skin impairment, presence or absence of edema, peripheral pulses, sensation, or movement. Skin prep can actually be used on the skin to help toughen it and protect it. And it's very important that pin site care is done because of the high risk of infection. So question, true or false? Observing the position of the cast is one of the 5 P's which the nurse should evaluate when assessing the child and assure it is properly documented. This is false. So just some pictures of different types of traction that you might see. In the top, we have the Buck's traction. The bottom is the Russell's traction. Then we have the Bryant traction to the right. We have the 90-degree to 90-degree traction. We have the balanced suspension traction. And we also have the cervical tongs traction. And in the lower right-hand corner, we have the Dunlap traction. These pictures are also in your textbook if you would like to see them there. We also have external fixation devices that are used with severe fractures, such as one extremity is shorter than the other, or the halo traction device, which is used to treat cervical fractures or after a cervical fusion. Special skin care at the pin sites is necessary, and they may leave the pin sites open to air, or they may require the Vaseline and gauze dressing. Really important to teach family caregivers and the child proper care. This will require work with a physical therapist during rehabilitation. And with crutches, this is going to be used to avoid weight bearing to the lower extremity with injury. And there's various types depending on the amount of weight bearing that's being permitted, the child's stability degree, whether or not those knees can be flexed, and the length of time those crutches are going to be needed, and what the specific goal is. The physical therapist should be teaching the use of crutches, and the nurse should be the one to reinforce the teaching. Osteosarcoma is a malignant tumor that's seen in the long bones, such as the femur, the thigh, and the humerus. It is more frequently seen in boys than in girls. An injury may be what is the factor that draws attention to pain and swelling, but it's not the cause. And pathologic fractures can happen with osteosarcoma. So it's diagnosed through biopsy, x-rays, bone scans, CT scans, or MRIs. And it will require surgical removal of the bone or the limb, followed by chemotherapy. Prostheses can be used after surgery. So nurses have to provide honest answers and support and help the child learn to live with their prostheses, and also encourage maybe joining a support group. And then we have the Ewing sarcoma, which is a malignant tumor found in the bone marrow of the long bones. This is often seen in the older school-aged or adolescent boys. So manifestations are going to be very similar to the osteosarcoma, where the injury itself will draw attention to the pain at the site of the tumor. They may have sporadic pain for a period of time, but it will finally become severe enough to keep the child awake at night. Metastasis may have already occurred by the time this is diagnosed. Diagnosis, once again, is going to be biopsy or a bone scan or a bone marrow aspiration. Does require surgical removal, radiation, and chemotherapy, in addition to support and encouragement through the entire process. Scoliosis. This is the lateral curvature of the spine, and it can be either structural or functional. It will be diagnosed through screening exams, usually beginning by age 10 or older. Scoliosis screening is required by some states in school, around 5th or 6th grade to at least the 8th grade. That initial screening can be done by school nurses, where we observe the back with the clothes for curvature of the spinal column. We're looking for symmetry of the shoulders and the shoulder blades or the hips, and the distance between the arms and the waist. We do this by having the child bend forward at the hips and touch their toes. And then we observe for the prominence of the scapula and the curvature of the spinal column. Treatment will depend on many factors. This will include non-surgical, surgical, long-term, and it will last through the growth cycle. TENS units and exercises, braces, and surgery might all be used to treat. Surgical treatment may require rods, screws, and hooks being placed along the spinal column to help realign the spine, and this could be very frightening to the child and the family. We need to deal with the postoperative pain. These clients are on complete bed rest and may be flat on their backs. It does require close monitoring of the neurovascular status of the extremities, and pain control might be done through the PCA pump. Foley catheter will be used because they're not going to be allowed out of bed for a while, and sometimes a body cast. Once recovery has occurred, these clients will be limited on some of the activities, and further growth may be inhibited. So, question. In what disease is electrical stimulation used in treatment? This is the scoliosis. Spina bifida is caused by a defect in the neural arch, generally in the lumbosacral region, and it may be associated with protrusion of the spinal meninges and spinal cord due to failure of the vertebrae to close. These clients will be very different depending on the type or the extent of the spina bifida. So they may be asymptomatic with no problems, or it can be very serious, up to and including paralysis. We might not be able to make clear-cut diagnoses based only on the symptoms. Diagnosis can be made through an elevated maternal alpha-fetoprotein level followed by an ultrasound that might show an incomplete neural tube. That elevated AFP in the maternal serum or amniotic fluid will indicate the probability of central nervous system abnormalities. These tests are usually performed between 13 and 15 weeks gestation. Diagnosis will be made from clinical observation and examination, an MRI, ultrasound, CT, and myelography. Treatment will depend on the extent. The surgical repair might be necessary. Therapy and highly skilled nursing will be required. Specialists will include neurologists, neurosurgeons, orthopedic specialists, pediatricians, urologists, and physical therapy. This is a very life-altering disease process. So, question. What is one of the major nursing interventions with a newborn who has a myelomeningocele? Is it family teaching, preventing hydrocephalus, preventing contractures of the upper extremities, or family interactions? This is family teaching. And now for your post-test.